evening, and thank you for being here this evening. Today, we are pleased to have Dr. Essam Manna, a very special guest from Asyut University Hospital. Dr. Essam is a professor of anesthesia in Asyut University Hospital and a neuroanesthesia in charge in King Khalid University Hospital in Riyadh as well in Saudi Arabia. Dr. Essam's specialty is in neuroanesthesia, and as well as he had a great experience in teaching and instruction, an instructor in CPR courses and other courses, and is teaching as well for the residents in Asyut University Hospital and King Khalid University Hospital. And today he will be sharing with us his expert opinion about awake craniotomy and about the anesthetic management of that. And with that, I ask you give your full attention to Dr. Essam and help me in welcoming him. Dr. Essam.
Thank you so much, Dr. Amr. Thank you, Dr. Saad, and everybody. Pleasure. بسم الله الرحمن الرحيم. والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. It is a great pleasure for me to meet the respected online course, mega online course, again in my second lecture in the field of neuroanesthesia. I had shared the opportunity, I think, 1 month back with my first lecture in neuroanesthesia about the basics and the principles of the neuroanesthesia. And by the way, I'd like to congratulate and appreciate the job of the organizing and scientific committee of the respected Megaline course, and congratulate the attendees, speakers, and the scientific committee for achieving the accreditation of the Egyptian Society of Anesthesia. And this course is officially now credited with 36 hour CME hours, as I think. And this is, I think, referred to the mainly for the scientific committee of the Megaline course, with respect to the leader of this course, Professor Dr. Saad Mahdi, who is my dear friend. So thank you so much, and I appreciate and go ahead with great progress and success, inshallah. Let us return back to my lecture today, which is about the anesthetic management of awake craniotomy. And as simple as my objectives of the lecture will be about the definition and the indication why the surgeons they are going to go for these procedures, with also highlight about very briefly about the history of the progress in the field of awake craniotomy and neuroanesthesia. Of course, we should have a goal or target for these procedures, and in the anesthesia room or anesthesia theater should be organized with a special organization in this procedure, because it is not usual procedure. It needs some organization between the all the staffs and the equipments inside the surgical room. The main core also, as we are mentioning every time, is the anesthetic management for this procedure. And we are facing most of the time in our practice challenge in the anesthesia, with a special challenge in this type of surgery. I'll provide and show the attendees one of the demo, because luckily we did just yesterday one fresh case awake craniotomy, And at the end, I'd like to introduce a home message for the anesthesiologists to get benefit from these lectures. Very simply, the awake craniotomy is a brain surgery performed on awake patients. And I'd like to give a message for my junior colleagues that don't be panic when you hear about the expression of awake craniotomy. It will be very simple, and you will be interested in doing such maneuver after finishing my lectures. And one of the target and the aim of my lecture is to make this idea and this issue is very simple, and to encourage you who are interested in the neuro anesthesia to go for trying the awake craniotomy, and of course under supervision of some of the expert people. Regarding to why the surgeons are doing these procedures, of course, there are certain intracranial pathologies which include procedures that require an awake patient for electrocardiographic mapping or precise electrophysiological recording, such as during epilepsy surgery, for example, and deep brain stimulation for Parkinson's disease. One of the indication is the resection of the lesion located close to or in the motor and the speech of the brain, and this is called eloquent areas. This is eloquent areas. Of course, there are some of the areas they are eloquent, but most of the eloquent area and or the precious area and the very important areas in the brain, on top of them is the motor and the speech area. Sometimes minor intracranial procedures that aim to avoid general anesthesia for faster recovery and earlier discharge, and this is facilitate the turnover of the cases and make availability of beds for other patients. So from the cost benefit issue, it is very important to turn on the beds for other patients. Also, obliteration or resection of vascular lesions that supply essential functional territories, one of the indication to do such operation. As a brief highlight of the history, as we explained in the previous lecture, if you remember, that we said that during the ancient times, thousands of years ago, patients were treated for seizures by trephine operation. And we explained that operation were done using some of the plants like belladonna, like datura, like opium, and sometimes after progress of the time, they use alcohol for sedation, and this was the trend at that time. After that, by progress of the time, they started to use local anesthesia in 1886, and after late in 1920s, when Walter Benfield was attempting to treat patients who had intractable epilepsy. By the date of 1934, one of the famous physician, Davidov, began to combine local anesthesia and sedation. And at the 1950s, Pasquet employed general anesthesia after testing with local anesthesia, and he explained this maneuver as vocal anesthesia. The first important change in the standard of anesthesia is dated back to 1959 when Castro and Mondelier introduced the concept of neuroliped anesthesia. And one of the famous physicians also, Archer, in 1988, he used analgesia and intravenous fentanyl, intravenous droperidol in the cases of awake craniotomy for epilepsy surgery. 4 years later, Silbergeld worked and he published the first data using propofol. This was a very important time. He used propofol sedation in awake craniotomy and considered to be the second great change to the field of awake craniotomy. In late 19th, several cases reports awake craniotomy were published in Asia. China and Indonesia also introduced awake craniotomy surgery in 2003 and 2007 respectively. Of course, we should have a target for this procedure. And the target for awake craniotomy is to obtain an accurate excision of the lesion while preventing functional disability to achieve, of course, a better prognosis and to improve quality of life for the patient. This is one of the main targets of the awake craniotomy. Also, possibility of reducing post-operative morbidity, thus facilitating early discharge from the hospital, as we mentioned before. But the primary goal of the anesthetist is to make the operation safe and effective, and while reducing the psychophysical distress of the patient. Now we are going to the main core of our lectures, and we will start by pre-operative evaluation. Of course, we should evaluate the patient health. He should be cooperative and to examine meticulously the airway characteristics. This is very, very important item because just we position the patient, the airway is a challenge for anesthetist who is performing awake craniotomy. Any patient he has any comorbidities, for example, should be excluded from the procedures. I mean uncontrolled comorbidity. If there is severe hypertension, our enemy, for example, is the morbid obese patients and the limitation of movement of the neck, for example. Patient who is complaining of previous post-operative nausea and vomiting. This is very important. Usually we are neglecting the history and asking about the post-POMV, post-operative nausea and vomiting. This is very important. And one of the general or global side effects of the anesthesia is post-operative nausea and vomiting rather than post-operative pain. Sometimes we are neglecting the post-operative nausea and vomiting. And if this happened intraoperative for the patient who is going for awake craniotomy, it will be a catastrophe. It will be a problem to deal with this case, with this intraoperative during awake craniotomy. It is a problem. So the patient health is very important. If the patient refuses the operation, this is absolute contraindication for the patient. You should stay with the patient and mention the advantage, the necessity, and the nature of the procedure. And if you have, for example, video and to show the patient what will go on intraoperative, this will be preferable because the cooperation of the patient and understanding of the procedure is one of the main core of the success of this operation. So you should spend time with the patient to give him some idea about the stage of the operation and what is the nature of the procedures. Of course, we are dealing with the science, and we should refer to the instructions and guidelines of some of the societies, such as European Society of Anesthesia or American or Canadian Society of Anesthesia. This is important regarding to the guidelines or policy and procedure of such procedures. Regarding to the pre-medication, some of the physicians or anesthetists, they don't prefer to give the patient benzodiazepines because recently Scholz has discouraged this administration before awake craniotomy because these types of drugs may reduce the pharynx muscular tone and influence the cognitive function and minimize epileptic foci. But actually, we are giving in our institute, we are giving the patient pre-operative benzodiazepines, short-acting midazolam, no hazards to give the patient, the adult patient, the cooperative patients 1 hour before going to the theater, 2 milligrams of midazolam because you should allay anxiety from the patient and avoid any apprehension from the patient, and the patient is going to the operative theater. So, and he will be to some extent awake, so you should allay anxiety, and this help a lot for allay anxiety and apprehension. One of the most important drugs and the magnificent drugs to be given for the patient is clonidine, alpha-2 blocker, alpha-2 agonist, sorry. And this, we can give the patient 3 to 4 mic per kg. This facilitates the sedation for the patient and also facilitate the stability of the hemodynamics of the patient intraoperatively and decrease to some extent post-operative nausea and vomiting. So it has a lot of advantage. Antiemetics are essential to be given for the patient because as all of us we know that one of the risky operations which predispose for post-operative nausea and vomiting are the brain surgery. So please give the patient antiemetic before going to the theater. Give as metoclopramide 10 milligram, or the best to give ondansetron. And sometimes in some areas, they give low dose of droperidol and dexamethasone are also used. But dexamethasone, there is one of the trick while who is using this drug from the experience. Don't give dexamethasone before giving analgesia or sedation for the patient because it makes some irritation for the mucous membrane. And it is very important drugs, by the way, dexamethasone, to be given for the patient to prevent post-operative nausea and vomiting. And by the way, in this event, it is very, very important, and it is approved as one of the drugs to be given in the complicated cases of corona. Intraoperative, the patient are permitted to wet their lips with water during surgery. Why? Because the patient is speaking, is breathing, and he's feeling with dryness. So it is allowed to give the patient some of drops of water and prefer to give the patient to hold a piece of ice and to give for the patient to prevent dryness during the procedure. Of course, one of the important preparation and arrangement is the operating room organization. This is very important. This is very important. The operating room temperature must be suitable, should be adjusted to prevent shivering of the patient, and should be comfortable for the patient. The surgical table itself must be covered with soft, thick dressing, and the surgical team themselves must instructed to speak and move only if necessary. Avoid any noise intra-operative. The patient face should look at the anesthetist at pictures, and the airway treatment during emergency, it is mandatory. So the patient face must be in position that allows him to look at the anesthetist and at picture during brain mapping, but must also be accessible for airway treatment during emergency. Sometimes an audio visual recorder system should be used or by the surgeon, so that the surgeon can see and hear the patient response during cortical mapping. Regarding to the draping for the patient, in our institute, we are using the same draping by putting screen, high screen, and we are not using this transparent screen, the usual screen which we are using in every operation, but to make the screen high. I'll show on the right side this picture from the internet, and on the left side this is the actual and the true settings of our theater. As you see here, this is our fellow in neuro anesthesia, and this side is the surgeon. They are doing their maneuver while the patient is sleeping supine with the same preparation and with the same screen. No need for making the screen transparent or something like this. This is the usual screen, but it is high to make, the purpose is to make access for the airway of the patient and to speak and interact with the patient, because he is awake, and at any time of emergency you can reach for the patient and you can manage very easily. Local anesthesia for the scalp is very helpful and one of the main steps in the success of this operation. We have 6 nerves in the scalp, should be anesthetized locally: supraorbital nerve, supratrochlear nerve, the auriculotemporal nerve, and the greater occipital and the lateral occipital. And as you see here, these are the anatomy, how to reach for the supratrochlear and the supraorbital and the other nerves. This is not enough. The patient, after giving some of this local anesthesia, may complain after that, because the main step is to cut for the scalp. So the scalp should be generously infiltrated with local anesthesia, but you should balance between giving a large dose of local anesthesia and to avoid the toxicity of local anesthesia. So you should be judicious in calculating the dose of local anesthesia. We are using, of course, ropivacaine or bupivacaine for infiltration of the scalp. Sometimes some of the anesthetists, they are anesthetized on these nerves on the same side of the incision, but better to anesthetize bilateral to avoid any chance of and to be generous with local anesthesia. This is very, very important step. After giving local anesthesia for the patient, now we start to put the screen and the surgeon start to scrub the site of incision. And now is the time for pinning. And at the site of the pinning, you should give local anesthesia, bupivacaine or ropivacaine, because the pinning is one of the most painful maneuver at all in surgery. So pinning and skin grafting, they are the most painful maneuvers in the surgery. So before putting the pinning, because it is it is very painful, you should give at the site of these 3 pins, 3 or 2 pins, you should give local anesthesia. After that, you adjust the patient position. So now we are going to describe the technique of the anesthesia. There are different techniques of giving anesthesia for awake craniotomy. And I advise the people, the neuroanesthetists who are interested to give anesthesia for the awake craniotomy, to fix his protocol and his regimen, not to try in every case many techniques or regimen for giving anesthesia. If you are happy with the technique you started, go ahead, because you will be expert and you can manage your case with the type of the intravenous anesthesia you are giving. Actually, we are not reaching to the level of anesthesia. We are giving the patient analgesia and sedation. Analgesia and sedation. In our institute, we accustomed to give the patient a combination of propofol and remifentanil. As you see here, propofol, and this is propofol and remifentanil. And some of the physicians, they like to work with dexmedetomidine, for example, and remifentanil. Others, they like to work with propofol only with local anesthesia, but we are accustomed to use the propofol and remifentanil combination. There are some of the tricks here. The operation may go from the start while the patient is awake but sedated, and you are playing with the level of the sedation. What I mean, that you are starting with good level of sedation. The patient should be cooperative. You should interact with the patient, speak with the patient, raising his arm, and respond to stimuli and respond to commands. So we are starting our regimen. We are starting with propofol infusion and remifentanil after giving local anesthesia and before pinning. We give propofol infusion at a rate of from 25 to 50 or from 30 to 50 mic per kg per minute, and remifentanil 5 to 1 mic per kg per minute, and adjust the level of the sedation according to the Ramsey scale. Usually, before pinning, the patient is deeply sedated, but keep the patient on spontaneous respiration. The whole operation, the patient should be spontaneously regarding to the respiration, breathing, spontaneous breathing. No chance to, the problem is to compromise the air way, the breathing. So deep sedation from the start, this is stage 1, making pinning, and after making pinning, decrease the level of propofol or stop even propofol infusion, and examine the position of the neck. The patient should be comfortable completely, not feeling pain, and should respond, and no complaint from the patient. So we start with propofol, as I said, infusion and remifentanil, and then pinning with local anesthesia, and then decrease the propofol infusion to make the patient almost awake, but he is pain-free. After that, the surgeon start to make incision. We can resume the infusion of the propofol and to provide it to keep the spontaneous breathing. I'm stressing about this point. Patient should be spontaneously breathing. And before reaching to the dura and doing the bone flap, the dura may be soaked with 5 minutes of bupivacaine. But some of the surgeons, they don't like this technique, as the patient is already sedated and pain free. So you are adjusting your case according to the case by case. The most important item or keywords here is to try to keep the force driving infusion ringer lactate or infusion fluid. So don't play. This is some of the points of the practical side. Don't play with this valve. Don't play with this valve. Make it fixed. Why? To avoid any increase or decrease of the driving force which drives the drugs going intravenously. By the way, the monitor of the patient, we are using the standard monitoring, as we know, all of us as we know, and we are applying invasive monitoring regarding to the blood pressure using pulse oximeter, ECG, and giving the patient nasal cannula or oxygen mask connected to the end-tidal CO2. After opening the dura and before reaching to the eloquent area, you should communicate with the surgeon. And here there is one point regarding to the stress of the operation. This operation, as it is, although it is very interesting and very nice, it is stressful. You cannot leave the patient. Usually our usual or casual surgery, you can leave the patient with your resident or your fellow, go outside and come every now and then. But this you should attend physically all the time of the operation. So it is very stressful for the anesthetist. Unless you have a fellow, you can deal with him and he is expert like you. You can interact with him and he can take over and you can go outside. But most of the time you should attend intraoperatively and you cannot leave the patient because the patient may deteriorate in a moment. So, as we said, when the surgeon starts to open the dura and he's reaching to the brain now is insensitive. And this is a gift from Allah, that the brain itself is insensitive. So don't worry, as the patient is stable, you are interacting with the patient, you are speaking with the patient, he is obeying the commands and moving his legs, his arms. And now the surgeon is reaching to the area of the tumor around the motor area or the speech area. And usually it takes 1 to 2 or 3 hours maximum. After finishing, they start to close the door. At this moment, it is called before opening, before removing of the tumor in the eloquent area or around the eloquent area. The surgeon is doing what is called mapping. And mapping to determine the site of the tumor and around the pressure, the important area, to avoid any hazards for this area or to remove more than enough from this area. Nowadays, we are depending on the clinical communication with the patient, and also we are using in the monitor neurophysiological monitoring. Why neurophysiological monitoring we are using while the patient is awake? Because neurophysiological monitoring, they give data and they give expression for any complication to happen very, very, very early than the response of the patient. So combination of the neurophysiological monitoring, evoked potential, I mean, with the clinical picture and clinical evaluation of the awakening of the patient is a good combination and results in a very nice outcome. So before starting to, and after mapping, and before starting to remove the tumor or vascular compression or whatever at this area, you should communicate with the surgeon. And about 15 to 20 minutes, you should stop or decrease maximally the infusion of the propofol to make the patient is sedated, but at level 1 or 2 for sedation. He should respond consciously and adequately to, because this is the critical period while removing of the tumor. So stop propofol infusion, and you may decrease, but not too much, the remifentanil. As I said before, try to fix the level of the remifentanil. And as we know that the remifentanil is a very rapid drug or short-acting half-life. It may be range from 2 to 20 minutes, and the context half-life of it is about 4 minutes. So it is turn on, turn off drug, as turn on and turn off drugs. And it is called, by the way, in the his trade name is Altiva, ultra short-acting intravenous anesthetics. So you should communicate with the surgeon to stop propofol about 15 to 20 minutes before going for the removal of the tumor. As the tumor is resected or excised, now the stress relieved from all the staff around and return back to resuming the infusion till the end of the operation. But this is not the full story. We didn't finish the story. We may face a lot of complication intraoperative. And this is very important. You should have a background how to deal with the patient. If something happened, you should deal with patient. And one of the important and the most important complication is the airway. If something happened for the airway, you cannot intubate the patient, but you have the, by worst scenario, you can apply LMA. And this is a very bad situation, which alhamdulillah, very, very, very rare to happen in every institute, because you know how to deal with the patient and how to deliver the intravenous drugs, and how to control the intravenous total intravenous anesthesia. Instance, it happens the respiratory suppression. You should search for the cause and treat it, give oxygen, and try to decrease the infusion of your drugs. And you should be ready for interference. The other complication, the seizures. It is one of the not uncommon complication, but it happened. The seizures and the treatment for the seizure from the surgical side and from the anesthetic side. From the surgical side, the best treatment is the irrigation of the brain with lactate drinks, cold lactate drinker. Cold lactated drinker. It aborts. It happened with us for in 2 cases, and it is focal, not generalized. Most of the time it is focal, and it is controlled by irrigating the brain with cold ringer. If not controlled, you may give some of the benzodiazepines in the form of midazolam, but you should be also very meticulous observation for the respiration, because the most important problem is the respiration. You should keep the breathing spontaneous all the time. Sometimes you monitor the end-tidal CO2, and it may go higher than 50 or 55. And what is your maneuver? What are you going to do at this time? The patient this indicates that the patient went for deep sedation. Decrease the infusion of propofol. It takes some time, and the patient regains his spontaneous breathing. Other complications, the hemodynamics, you should keep of the hemodynamics, post-operative or intraoperative nausea and vomiting because of the traction on the dura and some of the blood vessels. So you should give the patient anti-emetic, and by the luck, we are lucky enough because the propofol itself, it aborts the nausea and vomiting. So after finishing the excision of the tumor from the eloquent area, as I said, the stress relieved, and we can resume the infusion of propofol and remifentanil till the end of the operation. This is regarding to the anesthetic management. And as I said, you should be familiar with your technique. Don't try in every case. That's why we have challenge of the procedure. As I said, challenge this in the preoperative period. You should select and convince the patient and explain to the patient the procedures in every. You should prepare your patient and prepare your tools. Sometimes you may use neurophysiological monitoring. You may use bispectral index. Of course, invasive monitoring. And intraoperative, the position and comfortability of the airway is the main target of our procedure. The titration and infusion of the drugs, as I said, this is our enemy in awake craniotomy. And take care of the driving force of the infusion fluids. Don't play with it, make it, fix it. Dryness of the mouth, you give the patient some of the cold water or a piece of ice, mapping and awakening. We spoke about this. Homeostasis, of course, and temperature control. Increased intracranial pressure is one of the challenge intraoperative, and you should search about the cause of this, like increased end-tidal CO2, and you deal, as we explained, the seizures also, and the environment, makes the environment very calm and no unnecessary words or increasing in the voice. It is unnecessary. Luckily, yesterday we did one case, and I'll show you now how was the patient, alhamdulillah, responding very good, and he was fully awake, and he was reciting Quran while he is, they remove the tumor.
قل أعوذ برب الناس ملك الناس إله الناس من شر الوسواس الخناس الذي يوسوس في صدور الناس من الجنة والناس. حرك لي يده كده.
He's moving his hand while he recited Quran during the awake craniotomy. MashaAllah. Surgeon is comfortable with the patient and with anesthesia and with the procedures. This is our colleague. They are preparing for the bone graft. Now they are working on the brain after opening the view. It was very nice, alhamdulillah, and the pass very safe. And most of the time, like this. I'd like, at the end of my lecture, to give a home message or pearl of the awake craniotomy. And when you see this arrangement, asleep, awake, asleep, awake, asleep, it doesn't mean asleep. It means sedated patient, the level of sedation. But for simplifies, make it simple, we put the letters A, but should be explained like asleep, awake, asleep, awake, asleep. What does it mean? We start with propofol 20 to 50 mic per kg per minute, as we said, and giving remifentanil 0.5 mic per kg, pinning under still infusion and local infiltration. Stop only propofol 15 to 20 minutes before awakening. Position the patient should be comfortable and awake only. Remifentanil is running. Asleep again, start propofol infusion. Awake, stop only propofol infusion 20 minutes before tumor resection. And at the end, asleep, restart propofol infusion till the end of the procedure. It's very, by the way, it is very simple and very interesting. Some of the anesthetists, they like to use dexmedetomidine, remifentanil combination, but it takes longer time to resume sedation and consciousness, and also it affects on the hemodynamics. It decreases the blood pressures. The complications that needs shift to general anesthesia with LMA, and this is very, very rare, the respiratory obstruction, seizures, but we are treating with different maneuver, irrigation, using of the drugs, and intubation at the last, I mean the LMA. Bleeding, we should deal with if bleeding happens, we should deal with transfusion. If failed, unfortunately, we intubate the patient. Increase intracranial tension, awaken the patient by reducing propofol infusion. At the end, try to fix remifentanil. This is my message. Try to fix the remifentanil infusion rate. Stay with the patient. Don't leave the patient, please, because at any time the patient may deteriorate or go for any complications. and communication all the time in every case of anesthesia, not for the awake craniotomy. Communication, we should communicate with the surgeon. It is a relation like husband and wife. Of course, we are the husbands. And communication should be all the time between the surgeon and the anesthetist. This is my last slide. And this was taken in 2003 in University of California, San Diego, while I was there. And fortunately, I met these two guys. These are very famous guys in the world. This guy is this professor is the John Drummond. John Drummond is a pioneer in the neuroanesthesia, and he's writing all the chapters in the Miller every time. He is Canadian, and he was the chairman of the anesthesia department in University of California, San Diego. And I learned a lot from this man. He's very kind, as you see here, very kind person. And I don't know if he is still alive or not. I hope he's still alive. I lost communication with him. The other one is more famous than John Drummond. This is a Superman of the OR. This guy is the Jonathan Benmoff. This is the legend of thoracic anesthesia. So I was lucky enough to work with these people. I hope at the end that you, for the attendees and for the organizing committee, that you got valuable message from this lecture. And again, I congratulate the organizing committee and scientific committee with Dr. Saad, the leader, for the achievement of the Egyptian Society accreditation. And I hope the whole success and progress all the time, inshallah. Thank you.
Thank you, bro. Thank you, bro.
Thank you, Dr. Essam. Thank you.